by yes. So this is إن شاء الله في ميزان حسناته. شكرا لحضرتك دكتور عادل. And I will let أحمد فطين to introduce you. Thank you دكتور عادل.
شكرا دكتورة، ربنا يبارك في حضرتك.
أحمد. أحمد. دكتور أحمد فطين. He may be so. He may be busy also. So let me introduce you دكتور عادل.
دكتورة، لنا الشرف.
Dr. Adel, as I said before, he is one of the icon of critical care in Egypt and in all Arab countries and surrounding countries. Dr. Adel today will teach us what the intensivist must know, the golden number in ICU. Really, I suggest that it will be an amazing and fascinating lecture. Let us to hear from Dr. Adel, and finally, please put your question and Dr. Adel will answer. We have an open time up to 3 hours. Welcome Dr. Adel.
الله يخليك دكتورة، شاكر لحضرتك جدا جدا جدا. أولا بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على أشرف خلق الله المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أسأل الله تبارك وتعالى في هذه الليلة أن ينفعنا بما نقدمه، وأن يجعله يا ربي لنا وللجميع من العلم النافع ومن الأثر الباقي. السلام عليكم ورحمة الله وبركاته. It's my honor tonight to accept the very fruitful and really دكتورة صفاء أو Professor صفاء هلال. Really she amazed me every time she's committed to spread the knowledge to the anesthesiologists and the intensivists through her platform with our colleague Dr. Ahmed Fatin. So really it's my honor to accept this, I'm glad to accept this kind invitation from Professor Safa and from Ahmed Fatin. For tonight lecture, actually, Dr. Safa, my screen is shared and my voice is clear?
Yes, Dr. Adel, it's okay. It is running, Dr. Adel.
Okay. So actually, this is a series of lectures and titled, as Dr. Safa said, what the intensivist should know. And for being intensivist or any other specialities, usually we are looking for to be a good physician or a good doctor. So a very precise definition for who is the God physician and who is the great physician. Any difference between both of them? Yes. The God physician, it treats the disease, while the great physician treats the patient who has the disease. And this is by William Osler. And I like this quotation already because it differentiates between people who treat the disease and physicians who treat patients who have the disease, which make a difference, really. And I think Dr. Safa, through her platform and spreading the knowledge among many speakers from different specialities and countries. I think she is preparing us to be or sending us a message to not to be only a God physician, but our aim and her aim is to be a great physician. I think let me to just يعني say this is in Arabic what the intensivist should know. He should know. I drive from قاعدة عندنا في الإسلام ألا وهي ما لا يسع المسلم جهله. عندنا أحكام في العبادات، أحكام في الشرع للمسلم لا يسعه الجهل، يعني لا يمكن أن يكون جاهلا بها، زي مثلا لا يمكن أن يكون جاهلا بالوضوء، بأحكام الصلاة، أحكام الزكاة، أحكام الصيام وهكذا. فده اللي بنسميه ما لا يسع أي مسلم جهله. وبالقياس أخذنا the series of this lectures من هذا السياق، ألا وهو what the intensivist must know، اللي هو ما لا يسع طبيب العناية أن يجهله. وأخذت من هذا الجزء، طبعا عندنا أشياء كثيرة لا يسع الانتنسيفست أن يجهلها and he should know it from day one practice in the ICU. أخذت golden numbers in the ICU. Why golden numbers? Because every day in the round on daily practice, we are telling the resident, the fellows, or the nurses certain targets, certain numbers, and those numbers usually it have and strong evidence-based or proof to have a positive outcome on the survival for intensivist. So if you go through the scope of the critical care curriculum, you will find many dispersed golden numbers. And why I call it golden number? Because it has a strong evidence behind those numbers. It's not arbitrary numbers. And it proved to have a positive impact on survival of your ICU patients. This is why we call it golden numbers. And it should be known very well by the intensivist. And I think this is a very important lesson when you tell number for the RT or to the nurse, like target of blood pressure or target of MAP or whatever the target you put, you should have a rationale why you choose this number. When we talk about MAP, for example, in septic shock 65, why not 60? Why not 70? Why not 75? And other numbers that we can go through my presentation. دكتورة صفاء إذا تسمحي لي my presentation tonight will be شوية interactive حتى يعني تعم منها الفائدة.
Great.
It will be يعني I will start with brainstorming as a question, then I can leave the panel for you if you can choose one of the attendees to answer me, then we can go through. I think with this interactive approach will be better for me first and better for the audience.
Yes,
Can
great, Dr. Adel. A very good
okay.
idea. Thank you.
Okay, so you're welcome. So
let's go, Dr. Adel. Let's go.
So the topics of or the series of those golden numbers, I cannot or even anyone cannot make it in one presentation in one lecture. This is why I make it in a series. We may finish it in 3, 4, or 5 sessions. And it's very important also for people who are preparing them for the exams, for the OSCE, because it's an area of questions.
So January is yours, Dr. Adel.
الله يخليك دكتور، ربنا
We
يعزك.
are all ears for you. Thank you.
ربنا يخليك دكتور، ده شرف.
Thank you.
We have, for example, if we will go through the curriculum of the critical care, as I told you, we have the scope of the ICU is heterogeneous. So the golden numbers, it will cover most of those curriculums. And again, remember why golden numbers? Because it has an evidence from the literature, is there guidelines or meta-analysis or randomized controlled trial, or derived from a strong positive outcome on the survival. So we will have this series to cover, for example, golden numbers in the ERDS management. So I can ask the resident or the fellows or the RTs during the daily round or during the practice, what are the golden numbers in ERDS management? What are the golden numbers for weaning and liberation from mechanical ventilations? What are the golden numbers in management of sepsis and septic shock? What are the blood pressure targets, you know, in sepsis, in acute ischemic strokes, in aneurysmal subarachnoid hemorrhage, and intracerebral bleed? What are the golden numbers for intra-abdominal pressures? What are the golden numbers when you practice the BOCUS? What are the golden numbers when you apply non-invasive support, non-invasive ventilatory support like the BiPAP or the high-flow nasal cannula? What are the golden numbers when you support your patient with VV or VA ECMO or ECOR? What are the golden numbers in infectious disease critically ill patients, like the absolute neutrophilic count, the Candida scores, the Candida index? What are the golden numbers regarding those items for infectious disease in ICU? And there is certain golden numbers in general, like the shock index, the RV-LV ratio, the optic nerve sheath diameter, the large volume paracentesis, the Lights criteria for body fluids synthesis, the intracerebral pressure, the resuscitation endpoints, the perfusion indices, the delirium score numbers, the RAS scores, the PES, the TOF. What's the role of 20, 30, 40 in neuromuscular diseases? What are the golden numbers for critical care pharmacology, mainly the drug levels when you are addressing the PK and PD for critical care pharmacology. So if you can notice from those two slides, I highlighted many aspects in critical care patients. So let's start with the first question tonight with us addressing the golden numbers series. The question number one, and I need Dr. Safa Professor Safa to choose one of the volunteers to answer me. According to the Choosing Wisely for the Critical Care published in 2014, what are the golden 5 things physicians should practice in the ICU in daily basis? Choosing Wisely in 2014.
Yeah. My dear colleague, the floor is open for you.
Anyone can raise his hand to Professor Safa and can unmute himself, then he can answer me.
Yes, we have great fans for you, Dr. Adel. We have more than 70 people.
طيب نذوقك.
Thank you. Anyone want to share? It is not an exam. It is not for failed or pass, just to ask and brainstorm with each other.
It's a very interactive session. So any of our colleagues, he can just unmute himself and he start to share with us his knowledge. No problem.
So secure advanced airway and insert central line.
مين معايا من
This is محمد رجاء. He is
اهلا
a
دكتور
very
محمد رجائي،
very
اتفضل.
good volunteer. Every time he is
اتفضل دكتور، لنا الشرف دكتور محمد، اتفضل.
Yeah.
So what are the golden 5 things according to the choose?
Secure advanced airway.
Mhm.
Insert central line.
Mhm.
Do يعني ACLS.
Mhm.
hemodynamic monitor.
Be a good monitoring.
What else? Anyone can have other thoughts with Dr. Muhammad Rajai? Thank you, Dr. Muhammad. جزاك الله خير. Other
There
thoughts?
is someone in the chat box, Doctor. He
He
is answering
Dr.
assessment.
This is Professor Abdelkarim Al Ubaidi. He is the head of Jordanian Society of Anesthesia and Critical Care, and he answers the question in chat box, Dr. Ahmed.
So
He's a
Professor
great
Abdelkarim.
professor.
تفضل دكتور أحمد، تفضل.
أيوة. Assessment of the patient, interpreting the results, hemodynamics, lines and tubes, management stepwise, all those. This is the answer of Prof. Abdelkarim.
Okay, so we have answer from Dr. Muhammad Rajai and for Professor Abdelkarim. Thanks a lot for your input and for sharing. If anyone can unmute himself, one more.
Yeah. I'm sorry, Dr. Abdelkarim, not our Professor Abdelkarim. This is our colleague Abdelkarim, ICU registrar. I'm sorry, I don't know you. I'm sorry.
أهلا وسهلا. طيب غير دكتور عبد الكريم وغير دكتور محمد رجائي. Others?
Anyone
other thoughts about the choosing wisely for critical care phase published in 2014. Actually, this choosing wisely campaign was initiated as phase 1 in 2014, and they choose top 5 things that the ICU physician should practice on daily basis, and they label it as choosing wisely. Then phase 2 was published in 2021, like 3 years ago, another 5, so total of 10. Tonight, I will present the initial 5. Inshallah ta'ala, maybe the next session, we may address the next 5, total of 10, under labeling, what we call it, choosing wisely. And I encourage everyone can Google it, and he will find the evidence, and he can print it. He should put it in his smartphone or his pocket, and actually it should be one of the checklist of your daily ICU round. And it should be like a big poster or a flyer that should be in the dashboard of each ICU. So according to the choosing wisely for critical care in 2014, there was, as I mentioned, published golden 5 things that the ICU physician should practice. And this choosing wisely was a collaboration of the Critical Care Society and the American Thoracic Society plus the Critical Care Nursing Society. So it was a great collaboration, and they came with those 5 things that I call it golden 5 things that the ICU physician should practice every day during his round on management of his ICU. So those are the 5 top 5 things derived from the choosing wisely, the initiated like as a choosing wisely campaign, phase 1 in 2014. And as I mentioned, it was a critical care society collaboration between the Society of Critical Care Medicine, the American Thoracic of Surgery Society, and the American College of Chest Physician, and the American Association of Critical Care Nurses. What are those 5? Number 1, do not order diagnostic tests that at regular interval, like every day, but rather in a response to specific clinical question. And this is very important because every day in your practice, when you round on your patient, you order the resident or the fellow or by yourself daily CBC, daily chest X-ray, daily blood gas, daily ECG, daily liver function. So daily. So according to them, they found that from cost benefit, from anemia wise and blood extractions, those routine orders is not valid or are not valid in your ICU patient. ICU patient does not mean ordering images and labs on daily basis. So they derive that those orders which will answer a question for you, order it. If it will not answer a question for you, do not order it on routine on daily basis. What does it mean by answering? For example, your patient does not have GI bleed, does not have hemoglobin drop, and you are ordering CBC daily. Your patient does not have any cardiac problems, and you are ordering troponin or cardiac profile daily. Your patient does not have any coagulopathy. He's not in anticoagulation, or he's on subcut heparin or enoxaparin, and you are ordering coagulation profile daily. Your patient is not ventilated. He is on room air, and he does not have any respiratory issue, and you are ordering chest X-ray daily. So for what? You are adding cost, and you are ordering something that was not justified. Exposing the patient, for example, chest X-ray daily, you are exposing the patient for radiation, paying cost, transmission of infection. So why? Unless you have a specific clinical question will answer you from, for example, CBC, I am ordering for hemoglobin drop, from thrombocytopenia, from neutropenia or leukocytosis. ECG because patient had non-STEMI or acute coronary syndrome or STEMI or arrhythmias. So I'm ordering to answer my questions. Electrolytes on daily basis because my patient had arrhythmias, he's hypo or hypernatremia or hyperkalemia, has long QTC, for example, frequent BVC. So I'm ordering for a specific question to correct or to act. This is very important. So number 1 is do not order a diagnostic test on routine base or as every day, but it should be to a specific or a pertinent a question in your mind you need this stuff. So please abolish what we call it on daily basis on routine labs. Nothing is called routine labs in ICU. It's a specific question, pertinent question to be answered. You will save money, you will reduce the cost, you will minimize the anemia, and they are labeling us as vampires of the medicine, the people in the ICU. Why vampires? We are ordering daily labs, blood gas every 4 hours, lactate 4 hours, blood cultures, and electrolytes, and so on. So the patient usually enters the ICU with hemoglobin of 11 and discharged from ICU in 1 week with hemoglobin of 7 or 8. So we are vampires really. So please don't be vampire. Second item of those 5 things is do not transfuse bagged RBCs or red blood cells or blood transfusion in hemodynamically stable, non-bleeding ICU patient with hemoglobin more than 7. This is what we call a transfusion targets. So since long time, we are well aware about the hemoglobin target in critical ill patients 7 and above. For this transfusion target, it was addressed many times, liberal versus restrictive approach of transfusion. What does it have an impact? And I'm sure all of you are aware of this golden rule and golden number of 7 and above. Of course, there is exception if you have active bleeding, but remember now we are talking about hemodynamically stable non-bleeding patients with hemoglobin 7 or 7.5 or 8. But and you are not treating number, and they addressed liberal versus restrictive, and they found that less is more. And I think Professor Safa, she remember one presentation we presented through her platform was titled "Less is more," and this is one of less is more. When you,
it was great one, Dr. Adil. It was great one.
Exactly, Doctor. So when you pay less, you will gain more. This is in the ICU, and I think, as I told you, there is exception. Yes, of course, there is exception for patient of STEMI or active myocardial ischemia or acute stroke or acute bleeding. So again, it's case by case. But in general, this is very important. I think you should ask yourself on daily to minimize the blood transfusion with its consequences as a cost, as a volume overload, and disease transmission. And of course, there is no positive outcome if you compare restrictive versus liberal approach. So the positive impact is toward the restrictive approach. Number 3 is do not delay providing nutrition, preferring the enteral over the parenteral to critically ill patient during the first 24 to 36 hours of critical illness. So in early nutrition, of course, for your ICU patients during his critical illness, it has a positive impact in survival and maintaining the integrity of his mucosa or gout mucosa, reducing the translocation, and of course, enteral nutrition preferred to parenteral nutrition if there is no contraindication to use the bowl. But whenever there is a contraindication to use the bowl, like post-anastomotic or obstructive surgeries, so you are addressing with the surgeons or even for medical patients if they have lazy abdomen or high residual from his nasogastric tube for feeding. So you may delay it for 1 day and you reassess. But usually it should be addressed from day one. And it has proven that it has a really impact on your patient outcome and early discharge from ICU. Number 4 is do not deeply sedate your patient on ventilator without a specific indication or without daily attempt to do sedation vacation. What does it mean? Do not leave your patient heavily sedated, because every day you are addressing the sedation vacation or sedation holiday or sedation interruption to assess for readiness or preparedness for liberation from mechanical ventilation. Unless there is specific indication that you want to deeply sedate, for example, severe ARDS, traumatic brain injury, status epilepticus, for example, or pulse suppression, open abdomen, there is a specific indication to deeply sedate your patient. Otherwise, your patient will acquire the weakness and he will have difficult weaning and a long stay in the ICU. So every day you should put your target for sedation level through the score you would use or the device what you use, either PES or you use the clinical score RAS or Ramsey, whatever. So for such patient, I need light sedation analgesia. So my target should be, for example, 0 to 1, because the second day I will come to assess and to test him for weaning and possible extubation. And this should be done on daily basis. And this is one of the strongest items, or the biggest items that was addressed and proven to be of great value, which is the daily sedation, vacation, and assessment for preparedness for extubation. And it was proven to reduce the VAB, or the ventilator-associated pneumonia, and they put it as one of the bundles of in this VAB, or ventilator-associated event bundle, or VAB bundle, is daily sedation, vacation. The last one, or number 5, is do not continue life support for those at high risk for death or severely impaired functional recovery without offering the patients or their families the alternative of care focused entirely on comfort. What does it mean, or does statement addressing early code status or the DNR for people with palliative care, futile care, terminal cancers, does not have any intervention that may improve the outcome? Patient with multi-organ failure. Why? Because you are extending the support with ventilator, with renal therapy, with ECMO, with the, a lot of things that proven that in such case of futile care or terminal disease or multi-organ failure will not improve the outcome. So what's the idea behind those heroic measures? And the code status should be addressed early on those patients, and the family should know from D0 from starting of developing those critical illnesses, or when the death is imminent and nothing can be offered more. So you should address the code status. Those are the top 5 things derived from choosing wisely. And I encourage everyone of us should have it, or should print it and put it in his ICU as a dashboard, what we call it a checklist. And inshallah ta'ala, maybe the next session I will present another 5 were derived in 2000, or were published in 2021. And
sorry, just a comment to conclude this very, very great and very important for every physician, not for the intensivist also, is under the topic of personalized your care and investigation, tailored your therapy for your patient. Firstly, the investigation for any patient should be done for the requirement, what will be good to thoroughly investigate our patient, not a routine basis. Number 2, transfusion, which is sometimes it is dilemma. It has many dilemma about the transfusion in our country, especially in our country. That means that blood transfusion or plasma transfusion, we revived our patient again. We'll bring him from the mortality room to the vivid room. The other thing, early nutrition, early enteral nutrition is a good issue. Dr. Adil, even the bowel surgery, there is enhanced recovery after anesthesia, and they recommend that early enteral will not affect the anastomosis lines by many studies in many patients. Also, be careful when using deep sedation, and also tailored in some patients, as you mentioned, Dr. Adil, for status epilepticus and the TBI. And lastly, the alternative of care in palliative care. Thank you, Dr. Adil. Just to summarize these very important 5 points.
Thanks, Dr. Safa. I really appreciating this elegant summary for those top 5. And as I told you, there is another 5, inshallah ta'ala, we will present it maybe next week or week after. And when I ask my resident during the round, or my colleagues during the round, usually I derived from what we call it in سورة التكاثر. بسألهم دايما ما هي آخر آية في سورة التكاثر؟ ألا وهي ثم لتسألن يومئذ عن النعيم. فلما تكون في institution أو في hospital providing you the resources، وكلنا شفنا في الكوفيد how we suffered from resources deficiency أو reallocation of the resources. So for example, the point number one, it's addressing the resources. And of course, if you calculate the resources, those costs per week for each patient, you can imagine how much you reduce the cost.
Yes, yes.
For transfusion, how much you reduce the cost. Sedation, how much you reduce the cost.
And also
Addressing
they blame it in weather it changes all over the world. A ton of resources, syringe, airway devices, many gowns, many things emit carbon dioxide from the critical care after critical care.
Exactly. And actually, in our hospital, King Abdullah Medical City, as far as I remember, in 2019, we drive a pilot study for 2 months only as a matter of research between us in the ICU and the nurses. It was in the medical and surgical ICU and the cardiac surgery ICU, like around 35 beds. And we concentrate only on daily labs. And during the pilot study for 2 months, we printed the front page of the patient file. At that time, we have a hard copy file, not electronic file like those days. So we print the cost of each test in front of each test. For example, CBC, it will cost how much? The liver function, what liver function? Alk phosphate, it will cost how much? In according to the financial department in our hospital. And we put it in front, and we left it for the intensivist. When they ordered the labs, the nurse reminded him, please look for the indication, why, and the price. So when he found this, it was run for 60 days, 2 months, and it was very, very impressive to the extent that our charge nurse presented in our cluster at that time, because it reduced the cost of about 400,000 Saudi riyal at that time in 2019, in 2 months only, for 35 ICU beds.
Yes.
So it was very, very impressive that we did not include the X-ray, we did not include the ECG, only the labs that defined by ICU physician as routine.
Yes.
Really, really impressive, and it have a positive outcome. And طبعا, of course, the higher administration in your hospital, they will like you because you reduce the cost, of course.
Yes.
Okay, now we will move to the second question, and Professor Safa can choose for me a volunteer. My question, my second question is, how can you determine the depths of insertion of the CVC for the 4 sites of insertion, the right internal jugular, the left internal jugular, and the right subclavian and the left subclavian? I know most of you now, or nowadays, they have the ultrasound guided central line insertion. Of course, I know this. Now, and you have X-ray post insertion to confirm, and sometimes some people who are expert, they can use even the focus or the ultrasound to confirm the tip in the right atrium. But my question is for nurses who will ask you, Dr. Adil, I have before you go for scrubbing, she is giving you 2 lengths. One catheter is length of 15 centimeter, and other catheter is length of 17 catheter. Of course, if you have a lengthy catheter, so for example, you may find after insertion 7 or 3 to 5 centimeter outside touching the skin, because patient is too short or patient is too long. So you insert 15 and too long, so the tip just in the internal jugular end joining the subclavian. So from the start, before scrubbing, how can bedside you choose the appropriate lengths? 15, 16, 17, 20. Sometimes your stock is rich stock in the ICU, you have 20, and you have very lengthy patients or long patients or short neck. So how can you choose based on those 4 common sites? Most of us are familiar, I think, being anesthesiologist and intensivist, most of us are familiar with the IJ, right or left. Still, people also familiar with subclavian, right or left. So according to those sites, how can you choose the appropriate length of the catheter so you will avoid high up or too much in tip of the catheter of your CVC?
Yes, the floor is open for our colleague to share. Where is Muhammad Raga? He is the first volunteer. Muhammad, you will have a present from me. Just contact me privately, and then I will say to you what is your price. So Muhammad.
Yes, doctor.
Yeah, it is not an exam, Muhammad.
No, I wanted to ask, we suggest number 13, 14, 15 like this, or with tool like...
Centimeter. Centimeter.
Yes, right jugular, right internal jugular, I think 15, and right subclavian is 13 centimeter, and the left internal jugular is for 16, I think. 17, and left subclavian is 16. This is what I remember.
طيب based on what يعني your number based on what on valid equation ولا لو سألتك انت الآن في البيت سايد والنيرس بتسألك ليه يا دكتور why you choose 15 و 13 based on what يعني your clinical experience ولا معك مزورة يعني ولا معك اكس راي في ايدك وشايف يعني based on what you use those numbers.
This suggested by books before and experience it's valid يعني but
maybe اديني evidence طيب اديني strong يعني
no clear evidence for me but I think with extremes we are facing problems for this if patient is too short or too long like what you are telling but we are waiting for the evidence from you.
شكرا دكتور محمد. في احد عنده
Yes, there is our colleague Yahya Shawqi. He messaged us that 14 centimeter for right subclavian, 15 centimeter for the right internal jugular, 17 centimeter for the left subclavian vein, and 18 centimeter for left internal jugular vein.
شكرا دكتورة يحيى. بس نفس السؤال للدكتور محمد، منين الارقام دي؟ based on what؟ يعني عندك equation، عندك evidence.
Hello everyone. Just read them in a study.
اسمها ايه الاستادي يا طيب؟ بتقول ايه؟ الاستادي بتقول ايه؟
Study on Asian patient to determine the best insertion depth to the central venous cresta.
طيب الإيشيان دول منهم شورت
prospective cohort study.
طيب
yes
ما رأيك في الإيجيبشن زي حالاتي كده؟
I don't know about Egyptians but that this was the result of the study.
طيب بلاش الإيجيبشن عشان عندك تفرقة عنصرية. إيه رأيك في اليوروبيين؟ نعمل فيهم إيه؟ في الأمريكان، في الأفريكان نعمل فيهم إيه؟
Direct question about the study was does we need a formula to determine the depth or not?
هو ده
study
الكلام. انا
conclusion.
سؤالي ايوه هو ده السؤال بقى، ان احنا وي هاف فورمولا اوريدي. اديني بقى الفورمولا.
I don't know it exactly.
عشان الفورمولا بتجاوب لك على
all patient, all length,
اللينث
all
زي بالظبط الفنتليتر، وبتادريس الايديال بادي ويت، صح؟
Yes.
فهي
yes,
the
yes,
same.
Yes.
فبيزد
yeah.
based on this you have this formula.
Dr. Adel, there is
نعم.
our colleague Amr Kamal text us that according to the formula, the length of CVC insertion should be height divided by 10 for the right internal jugular vein, and the height divided by 10 minus 2 centimeter for right subclavian, height divided by 10 plus 4 centimeter for the left internal jugular vein, and height divided by 10 plus 2 centimeter for the left subclavian vein.
Excellent, Dr. Amr. Very, very excellent answer.
Thank you, Amr. Thank you, Amr.
Thank you, Dr. Amr. Thank you very much. And this is what we need to know from the golden numbers series، ان يكون عندنا strong evidence او يكون عندنا equations that we use it، زي equation of ideal body weight. لو ما عنديش مثلا سمارت فون او ما عنديش فنتليتر بيحسب لي الايديال بادي ويت، او ما عنديش كلينيكال فارماسيست، المفروض I should know what's the ideal body weight equation. مثلا الجي اف ار equation how can I drive، الكيو تي سي interval equation، وهكذا. فعندنا certain important equations في الاي سي يو، منها هذه الايكويشن. طبعا انا why I presented زي ما بقول لحضراتكم انه ممكن جدا الستوك عندك يكون فيه variable lenses، وانت بالتالي عندك variable length of patients، ما هو شورت نيك، فتحط السنترال لاين ال 17 تلاقيه penetrating to the RV واريثمياز، والعكس لونج بيشنت وتحط له اي جي وتلاقي التب يدوب touching الجنكشن او residing at the junction of subclavian with the internal jugular. So according to Dr. Amr mentioning this, so دي قولة الفورمولا نفسها اللي ذكرها الدكتور عمرو، اسمها بيرز فورمولا. السيد بيرز قال لا احنا مش هنمشي بارقام اعتباطيه، احنا بما ان احنا الرايت سايد هو الاقرب للرايت سوبيريور فينا كافا، للسوبيريور فينا كافا، يبقى هو ده يعني اللي هيكون شورتست لينث، والليفت سايد سواء كان ليفت انترنال جاجلر او ليفت سب كليفن هو ده اللي هيكون، لان ده بيكروس الميدل لاين عشان يروح في السبيريور فينا كيف، ويروح وبعد كده يريسايد انتو ذا رايت اتريوم. يبقى هنا اللي هيحكمنا الا وهو الهايت اوف ذا بيشنتس. فبيزد اون ذا هايت، فقال الفورمولا اللي ذكرها لنا زميلنا الفاضل دكتور عمرو، وقال ان اللينث of the CVC insertion زي ما تفضل دكتور عمرو هتقسم الهايت على 10. ده في حالة لو انت رايح على الرايت انترنال جاجلر، وهوريكم بعد كده اكزامبل. ده لو الرايت انترنال جاجلر، لو احنا لسه على الرايت سايد، لو انت على الرايت سب كليفيان نفس الهايت على 10 بس تطرح منه 2، لان السب كليفيان هنا هيبقى شورتر لينث، لان يا دوب هتعمل السي شيب من السب كليفيان وتجو الى السوبيريور فينا كيفا، ما عندكش انترنال جاجلر لينث. ده يبقى 10 هايت على 10 للرايت انترنال جاجلر، هايت على 10 وتطرح منهم 2 ده للرايت سب كليفيان. نروح على الليفت، قلنا هو هيبقى مور لينثي، اطول عشان الكورس كروس، فهيبقى الهايت على 10 ثابت، هتضيف 4 مش هتطرح بقى، هتضيف 4 يعني بلس 4 لو ليفت اي جي، وهتطرح سوري وهتضيف 2 بلس 2 لو الليفت سب كليفيان. وهديك الاكزامبل، ولقوا انه كايفيدنس بيز لقوها انه this Perez formula it represent 95% accuracy for predicting the required line depth. واحنا عارفين انه بعد ما بتخلص بتعمل اكس راي، وايدلي the tip of the central line should be 1 to 2 centimeter below the carina. دي عشان تقول لك ان انا في الميد رايت اتريوم، not too much رايحه ترايكاسبيد او هاي اب في ال في junction of subclavian and superior vena cava. So subclavian. So it has a high prediction rate reaching up to 95%. البيريس formula for those 4 sites زي ما قلنا على الرايت internal jugular هيكون الهايت divided by 10. على الليفت اي جي هيكون الهايت بلس 10 سوري divided by 10 وتضيف 4 يديك اللينس هايت divided by 10 ونطرح منها 2 ده في الرايت سبكليفيان. هنا هايت على 10 وتضيف عليها 2. يعني فور اكزامبل خلينا نقولها ان اكزامبل، لو رايح على الرايت انترنال جاجلر ومريض طوله 170 سم 170 على 10 يبقى 17، يبقى هطلب من النيرس تديني لينس اوف 17، ما تدينيش لينس اوف 15 هيكون شورت، وما تدينيش لينس اوف 20 او 18 هتكون يعني 18 اكسبتبل، لكن مثلا 20 وده كومن في السنترال لاين عشان الفيمورال وده هيكون تو ماتش ان، يعني ممكن نروح على ترايكاسبيد فالف. نفس الكلام لو هتروح سب كليفيان، نفس المريض لو هتروح له سب كليفيان طيب هايت 170 على 10 ماينس 2 يبقى هنا هتاخد 15 لينس 15، ما تاخدش لينس 17 لانه برضه نفس الكلام هيكون تو ماتش. فاعتقد الاكزامبل كده واضح from مستر او from دكتور بيرز formula. So remember it is height by 10 ده القاعده either without adding يبقى على الرايت انترنال جاجلر، تطرح منها 2 على الرايت سبكليفيان، تروح على الليفت بالبلاسز، تضيف 4 لو في الليفت انترنال جاجلر وتضيف 2 لو انت في الليفت سبكليفيان، هيديك اللينث. وthis is with accuracy remember for accuracy of 95% to predict the appropriate tip of your CVC. وده example زي ما وريت حضراتكم انه this is in red arrow, this is the tip of your right internal jugular، وهنا البلو arrow this is the carina. فاحنا دايما 1 to 2 centimeter at the level of carina. هنا one of the appropriate sites of the catheter tip. For the left internal jugular again هنا الريد هي التب، الكراينا زي ما قلنا هنا لينثي مور لينثي عشان زي ما قلت لحضراتكم انه كروسز ذا ميدل لاين، وده شرط اكيد انه تشود النورمال اناتومي شود كروس ذا ميدل لاين. الرايت سبكليفيان شورتر وهو التب should be 1 to 2 centimeter below the carina. الليفت سبكليفيان this is the left subclavian شرطها بما انه على الليفت should القاعده انه it should cross the middle line. ليه؟ لان الرايت سبكليف لان السوبيريور فينا كيفا في الرايت عشان يفتح الرايت اتريوم، فلازم الكورس بتاع الليفت اي جي والكورس بتاع الليفت سبكليفيان لازم it should cross the middle line ويكون 1 to 2 سنتيمتر، ما يكونش هاي اب. طبعا بنشوف بقى احنا يعني فاريشن، نشوف واقف هنا مش عارف رايح على الليفت سبكليفيان it turns to the contralateral side and so on. ده الفورمولا اللي هي البيريز فورمولا.
دكتور عادل من فضل حضرتك
اتفضلي.
the question from our colleague Muhammad Usama, he asked that regarding intrajugular and CVC insertion there is different approach, high or lower, also there is posterior approach. Can we apply an equation for all?
لا هنا الايكويشن is not for the insertion approach. الايكويشن هنا for the length according to the height.
Yes.
طبعا اوقات بيكون الستوك في الاي سي يو ما عندوش غير 1 لينث، هو ده الستوك اللي افيلبل، خلاص انت مضطر مجبر اخاك، بس ده تاخد في حسبانك انه ال 15 will not بي سيتابل لو انت رايح على اي جي. عشان كده مثلا روح سب كليفيان افضل لو عندك مريض مش اوبيز ولونج نيك او طول نيك، ما تروحش بقى او عندك 15 شورت هي دي الافيلبل 15 لينث. بص عشان كده بقول لك مهم جدا انك تبص قبل ما تبص في الباك قبل ما النيرس تفتح لك الباكج عشان تعرف انت المفروض تروح سب كليفيان ولا تروح اي جي، تروح رايت ولا تروح ليفت. يعني ما يبقاش عندك لينس 15 وتروح ليفت اي جي مثلا، لانه انت محتاج يعني اتليست 18، خصوصا انا بتكلم لو شورت نيك او تول نيك. تمام.
اوكي.
طيب now we will move for the third question. واي ثينك كده هكون تقلت على حضراتكم، لانه احنا كده تقريبا 45 دقيقة، وطبعا زي ما حضراتكم عارفين بعد 45 دقيقة يعني نص ساعة ل 45 خلاص الناس هتنام منا وهيبداوا يكرهونا يا دكتورة صفاء.
لا خالص، لا
ف...
لا بالعكس،
الله
كل ده
يخليك.
النمبر بيزيد ما شاء الله بنسبة الحضور، وبعدين
الله
الناس
يخليك.
بتبقى مع حضرتك يعني في حتة تانية بصراحة يعني.
الله يخليك يا دكتور.
ربنا يكرمك، ربنا
يا
يرضى
رب.
عنك.
وياك يا دكتور. طيب we will go now for the third question, and I need from Professor Safa and Dr. Ahmed Fatin to choose one of our volunteers غير محمد رجائي. So
He's a good man. محمد رجائي is good man.
ربنا يبارك فيه وينفع بيه يا رب، اللهم امين. معانا الناس اللي على الشات زي الدكتور عبد الكريم والدكتور يحيى يسمعونا صوتهم يعني. طيب السؤال الثالث بيقول what are the golden core 4Ds of source control in sepsis management. For sepsis management عارفين انه one of the important challenges عندك هي السورس كنترول، مش الانتيبيوتكس بس، مش الفلويد ريسيستيشن بس، مش الفازوبريسور فقط، لكن عندك most importantly is the source control. السؤال بيقول what are the golden core 4Ds كلهم 4 intervention بيبدأوا بحرف الدي for source control in sepsis, and we consider it as golden number. So when you face patient with sepsis or septic shock, you should address early زي ما بتستيت with fluid، زي ما start vasopressors، زي ما start antibiotics. You should address the source control. سؤالي على ايه هم ال 4Ds core for source control in sepsis and septic shock.
My colleagues. So the man of the impossible mission, Dr. Muhammad Raja, you are the man of impossible mission. Can you join us, Muhammad? You are here?
Yes, I am still here. Debridement, maybe decompression, like decompression laparotomy or something.
Yeah, there is also Abdul Munaim Gamal, our colleague, said drain, debride, and device removal. Anyone also?
I ask my colleagues just to unmute themselves and share with us. يعني ما فيش مشكلة، ممكن بس من unmute ويشارك معانا.
Excellent.
could be السلام عليكم دكتور عبد المنعم جمال.
أهلا وسهلا.
أهلا وسهلا. أهلا وسهلا دكتور. هو الفيرست maybe the drainage of the infected fluid in any space like empyema. The second debridement, like example like neck fasciitis. The third is device removal in case of candidemia or eclampsia. or visible infected, and the fourth I could not remember, Dr. Radi.
جزاك الله خير يعني excellent.
Dunya said that the detection of source and the drug of choice. She said 2D detection of source and the drug of choice.
Okay. Excellent. So I think most of you answered the core for these, and the question is to address the importance and the positive outcome of source control early in sepsis, because sometimes we concentrate on antibiotics, fluids, and we delay. I will not tell to forget, because we will not forget, of course, alhamdulillah, lakin we delay the source control. And this is very, very crucial to clear the focus, to reduce the bacterial or fungal burden. So as you mentioned that those are 4Ds. Why? Because the appropriate source control, as we mentioned, is a key principle in management of sepsis. The source control of the infectious focus was proved to have a positive impact on survival improvement in many literatures, plus randomized controlled trial. And of course, it was one of the recommendation in the surviving sepsis campaign, different versions. Source control should be achieved as soon as possible once you start the initial resuscitation in the ER. The issue is of the time frame. The issue for time frame, until now, the guidelines or the surviving sepsis campaigns publications in 3 versions do not put a specific time frame, which is very important in my opinion. They put initially, if you remember, the 1-3-6 hour resuscitation, the 1 hour for antibiotics, but for the source control, they could not identify exact time frame. They mentioned as early as possible, because when you manage patient with sepsis, for example, if you need to remove the line, he's coagulopathic, his INR is 4, he's thrombocytopenic, it's not feasible to remove, for example, permacath. It's a tunneled catheter, it should correct the coagulopathy first. So you cannot put a time frame within 1 hour. For example, debridement, it needs correction of the coagulopathy, the optimization of the hemodynamics. Our anesthesia colleagues, they will not take him while he's unstable to the OR for debridement unless you stabilize him first, and so on. So the time frame is very difficult in defining a specific time frame, but it should be as early as possible, because delaying those source control for sepsis, of course, will make your patient processing or progressing from sepsis to septic shock to multi-organ, and of course the antibiotic per se will not play the principal role. And there is certain smaller studies, they suggest a definitive source control between 6 to 12 hours, and they found those especially in soft tissue infection, in necrotizing fasciitis, mycosis. So the as early as possible. So they put 6 to 12 hours a time frame, so you can correct the coagulopathy, stabilize your patients, and prepare the OR, the resources. So in 6 to 12 hours, of course, most of things can be achieved during this time frame. But again, if earlier than this, much better. Who cares? يعني you can go after 1 hour, fine. 3 hours, better. But do not delay it beyond 12 hours. Of course, the cascade of sepsis will not wait for you. And those are the core these of source control derived from the SCIM live, and the as our colleague mentioned, the first D is drainage. D for drainage, the first D, drainage of any suspected collection that could be a source. Abdominal collection, like in pancreatic collection, pelvic collection, subhepatic collection, empyema. So cavity, any collection that proven to be the most likely source should be drained as early as possible. And of course now the bedside drainage by interventional radiology, or even in the radiology suite, طبعا facilitate things early. So drainage is the first D. Second D is debridement. Of course, the debridement plays a role to decrease the or to get out of those infected or dead tissues, diabetic foot, neck fash, soft tissue infection, gangrenous parts of the skin, or extensive bed sores. So debridement here plays a very important role, because you are removing the unhealthy dead tissues and exposing the healthy tissues. So this is second D. Third D, as Dr. Muhammad mentioned, is Dr. Abdullah mentioned, that the device removal. When you face a patient with sepsis, you are looking for what lines does patient have. Does he have central line? And there is, for example, no cultures still positive, but clinically patient had permicast or dialysis catheter or Heckman or femoral central line. So there is, for example, patient presenting with fever, rigors, hypotension, leukocytosis, and this is most likely source. It should be taken out. This is regarding the line. Police catheter, infected drain, infected pacemaker, for example, wire or battery. So any device infected AVD drain, external ventricular drain for CSF, any device that's suspected to have been or to be the source of sepsis, the antibiotics will not play the principal role. Device removal is the third D. And the last D is definitive measures. What I mean by definitive measure, if your patient presenting, for example, with perforated bowel, the definitive measure is not device removal, is not debridement, is not drainage, is to open the abdomen, laparotomy, and to get to manage this perforated bowel, perforated appendix, perforated gallbladder, rupture spleen. I mean, when you have a ischemic bowel, gangrenous bowel. So this is a resective intervention. This is a definitive measure. Patient had Weber disease and now he has leak, an stomatic leak. They should go and open. This is a definitive, like patient with hemorrhagic shock and he's bleeding inside the abdomen, is the definitive measure. So this is a definitive measure regarding the source control of, for example, intra-abdominal sepsis. So this is the 4 Ds. Remember, first D for drainage, second D for debridement, third D is for device removal, and the last D is for definitive measure. And remember, when you delay those 4 Ds, you are delaying the source control, or are delaying the sepsis management. Example, which is usually when we practice medicine, we should adding no harm. So please do not delay the source control. Address it early, and this is of great value when you addressing the survival in sepsis. Remember, not only the antibiotics, not only the fluid resuscitation, not only the hemodynamics. Remember, part of your management core is the source control with its 4 Ds. And this is the evidence and the guidelines recommendation. Since 2018, for example, this is regarding the soft tissue, skin and soft tissue infection. They recommended at least in the first 12 hours as time frame from admission, you should address early source control for surgical debridement. While in Surviving Sepsis campaign, with its edition in 2021, for septic shock, they recommend rapidly identifying or specifically addressing the diagnosis of infection that require emergent source control and implementing any required source control intervention as soon as medically and logically practical. هي دي اللي كنت بتكلم عليها، ان مفيش تايم فريم هنا من السرفايفنج سيبسيس كامبين. يعني يمكن من السلايد السابق، اللي هو هنا في السيسكين السوفت انفكشن قالوا في اول 12 ساعه، لكن في السرفايفنج سيبسيس كامبين قالوا as early as possible on emerging cases as medically and logistically practice. زي ما قلت كده medically يعني coagulopathy hemodynamic instability. logically ما فيش لسه الانترفنشن راديولوجي موجود. الفاسكولار سيرجي عشان يجي يشيل لك البرميكاس لسه فار اواي منك، ودي طن ديكاستر ما ينفعش انت في الاي سي يو تشيلها. انترفنشن راديولوجي لازم يجي يعمل درينج، فعقبال ما تكلموا اون كول والساعه 3 الفجر يعني this is as early as possible. وهنا يعني ياتي دور الانتنسيفست انه بيقف على رجليه وبيقول لا this is يا شباب سورس كنترول، زي ما الانتيبيوتكس والفلودرستيشن معايا another limb or another arm which is the source control. I need to be tackled as soon as possible. ما سابوش للصباح، ما سابوش لبعد الظهر، ما سابوش از هوم ورك للزميل اللي ورايا. لازم ارتب له من البدايه من الاي ار. ولو تلاحظوا هنا الريكومنديشن دي ما خدتش ايفيدنس 1A or 1B، وخدت ايفيدنس اللي هو البيست براكتس ستيتمنت. I think دكتورة صفاء with those 3 questions I can stop here. أعتقد yes I can stop here. أشكركم جزيلا، ويعني أعتذر لكم لو كنت أطلت عليكم في خلال ساعة تقريبا. إحنا بدأنا تقريبا بقالنا ساعة. إن شاء الله تعالى يكون من العلم النافع. وأشكر مرة تانية أستاذتنا الجليلة دكتورة صفاء وزميلنا الحبيب الفاضل دكتور أحمد إن ادوني هذه الفرصة to interact with you، وأرجو إن أنا أكون قدمت شيء يعني ينفعني أولا وينفع حضراتكم، وربنا يجعله في موازين حسنات الجميع. وشكرا جزيلا. Thank you.
طبعا دكتور عادل هو من العلم النافع ان شاء الله، ويعني احنا مش هننسى الحديث الشريف اللي حضرتك علمته لنا. ان شاء الله يستغفر لك حتى الحوت في البحر، ويستغفر لك النمل تحت الحجر، وربنا يتقبل من حضرتك ويكرمك يا رب ويحفظك يا رب، اللهم امين، ويكبر خاطرك ان شاء الله. دكتور عادل ان شاء الله احنا السبت الجاي باذن الله هنكمل
ان شاء الله باذن الله. لو ما كنتش ضيف ثقيل على الناس والزملاء تحت امرك.
لا it's a great honor and pleasure. شكرا يا دكتور عادل، ربنا يكرمك. شكرا
ثانك يو بروف، ثانك يو سو ماتش، وشكرا لكل الزملاء الحاضرين. وطبعا كالعاده لازم ننوه ان المحاضره مسجله وسترفع على قناه الجمعيه المصريه على اليوتيوب
ان شاء الله. ان شاء الله.
شكرا جزيلا.
شكرا لحضرتك يا دكتور عادل.
الله
شكرا
يخليك دكتور.
تصبح على خير.
شكرا.
تعبنا حضرتك
على خير.
والله، تعبنا حضرتك، وحاسه ان حضرتك عطشان والله يا حضرتك. عفوا معلش معلش، ربنا يكرمك. شكرا
يا رب.
شكرا. ثانك يو. ثانك يو.
شكرا دكتور احمد فاطين، وشكرا دكتور عادل. مع السلامه.
الله يخليك.
السلام عليكم.
السلام عليكم.
السلام عليكم.